Welcome to another lecture on blurring of vision. I am Darby Santiago, and I will be introducing you to a group of eye disorders, which we will collectively call as uveitis. Everybody knows that the main function of the eye is sight. So if there is something wrong going on inside the eye, you often get blurring of vision. People who suffer from uveitis are no exception. They usually end up suffering from a blurred vision, and in some unfortunate cases, even permanent loss. In this course, we will learn about the structures involved in uveitis, their classification, how they cause blurred vision, and more importantly, we will also learn how to recognize uveitis by knowing the clinical eye findings that differentiate uveitis from other causes of blurring of vision, such as glaucoma, infectious endophthalmitis, conjunctivitis, eye diseases. To begin, let us define uveitis. In classical terms, it pertains to a group of inflammatory diseases that involve the uveal structures. The uvea is composed of the iris, ciliary body, and the choroid. If you are not familiar with these ocular structures, please stop and review your notes in anatomy first. If only the ciliary body is inflamed, we can use the term cyclitis. Similarly, we use iritis if only the iris is involved, and choroiditis for the choroid. If both the iris and ciliary body are involved, then we call it iridocyclitis. In some cases, all three parts of the uvea are involved, and this is what we call panuveitis. In this photo, we see that the conjunctival vessels are engorged and tortuous. Some of you may diagnose this as conjunctivitis due to viral infection or sore eyes. However, if we look at the irregular shape of the mid-dilated pupil, we can say that something else is going on inside the eye. This eye is actually has an inflamed iris and ciliary muscle, or what we call iridocyclitis. The irregular shape of the pupil is due to the adherence of the posterior surface of the iris to the lens due to the inflammation. Notice also that despite the prominence of blood vessels, the conjunctival tissue itself is not inflamed, since it remains thin and shiny, unlike in your viral conjunctivitis. Here is another example of a red eye with a more subtle presentation. It is more of a pink eye. What is remarkable about this photo is the white pupil, or what we call leukocoria. Vision could not be more than hand motions with good light projection due to this cataract formation. But let us focus on this part of the cornea. You can see some brown spots at the back surface of the endothelial surface of the cornea. These brown spots cast shadows on the iris surface. A more magnified view will confirm the presence of what we call pigmented keratoprecipitates, which is commonly seen in acute anterior uveitis or even those with history of past uveitis. You can check the presence of these lesions in your patients by using your ophthalmoscope and setting the rotary lens to the highest plus available. The brown appearance is due to the pigments liberated from the inflamed iris. If they are thick enough and centrally located, they may cause blurring of vision. Shifting now to the inside of the eye. What if the inflammation involves the retinal blood vessels or the vitreous? Should we count them also as uveitis? In actual clinical practice, the term uveitis can be applied to any intraocular inflammation, even if the inflammation does not predominantly involve the uveal tissues. To illustrate further, please refer to the fundus photo on the left. The green arrows point to retinal vessels that have been coated with white material. The white coating is actually an accumulation of leukocytes that is attacking a foreign entity and clinging onto blood vessel walls. This is what we call vasculitis. Vasculitis is a common feature in quite a number of local and systemic inflammatory diseases, such as your cytomegalovirus. Not all blood vessels are inflamed in this fulminant type of CMV retinitis, but notice the extensive formation of lipid exudates which has spilled into the retinal layers from the leaking inflamed blood vessels. The blood vessel walls has also weakened with some bursting resulting to hemorrhages. Another example of uveitis involving non-uveal tissue is this case where the vitreous is filled with white fluffy materials. The green arrow is actually pointing to retinal veins, which can hardly be seen. The vitreous is hazy because of the presence of inflammatory cells within it. Some inflammatory cells may clump together to form balls. This is what we call vitritis. So, why does the uvea get inflamed? What causes the inflammation? There are many underlying causes of uveitis. Some can be due to microbial infection like HIV, herpes, syphilis, and toxocariasis. Others arise from autoimmune disorders like systemic lupus erythematosus, rheumatoid arthritis, ankylosing spondylitis, TB, juvenile idiopathic arthritis, Vogt-Koyanagi-Harada syndrome. Or they may be due to an underlying carcinoma. There's a whole myriad of causes which you can look up in your textbook anytime, but there is no need to memorize them. One thing that I would like to emphasize, though, is that certain carcinomas, such as lymphoma, may masquerade as a uveitic process, either in front of the eye or at the back of the eye. Here is another example of what appears to be retinal vasculitis. There is the typical confluence of white inflammatory cells along the vessel walls. This is actually a patient suffering from chronic leukemia whose retina has also completely detached. If we are not diligent enough in our history taking and ophthalmic examination, we can miss out on the diagnosis and may end up not only losing an eye, but the patient's life as well. Awareness and knowledge of the clinical signs and symptoms of uveitis and prompt referral may save the life of a patient. This leads us to the next question. How do patients with uveitis present in our ophthalmic outpatient department? The answer depends on which anatomic parts of the eye are affected and the severity of inflammation. The most common signs and symptoms are eye redness and pain, blurry vision, light sensitivity or photophobia, floaters, and decreased vision. The symptoms may appear singularly, but most of the time the patient will report various combinations of these symptoms. The onset of symptoms may be sudden, or they may develop gradually. They may appear all at the same time or one after the other, in one or both eyes. Notice that the symptoms listed are not exclusively seen in uveitis. Therefore, it is important for us to learn how these symptoms come about in the background of uveitis. Let us start with the most common. The redness in uveitis is a reaction to the inflammation happening in the anterior segment of the eye or the iris, and in some cases, the ciliary muscle. In the photos given, all three eyes appear inflamed. So how will you know which one is due to uveitis? We need to look at each eye carefully and note features other than vascular dilation. Looking at the top photo, we see copious amount of purulent eye discharge. This implies the presence of bacterial infection. This is bacterial conjunctivitis due to Neisseria gonorrhea and is not considered as uveitis. The eye in the lower left photo shows severe palpebral conjunctival swelling on lower lid eversion. There is watery to mucoid non-purulent discharge. These features are more characteristic of either viral or allergic conjunctivitis and not uveitis. The last photo shows 360-degree prominence of the small blood vessels at the borders of the cornea, or what we call the limbal area. This is what we call ciliary injection. Ciliary injection is a common feature in eyes with anterior uveitis. The rest of the conjunctival vessels may appear normal to slightly dilated, but not tortuous, giving rise to a pinkish hue of the eye. Please note the absence of eye discharge. When you encounter patients with ciliary injection, you should ask for the presence of eye pain. If there is, ask if the pain is more severe when he is exposed to sunlight, a symptom termed as photophobia. If it is worse, then this may strengthen your suspicion of uveitis. Pain on pupillary constriction is due to the forced contraction of inflamed ciliary muscles in an eye with iridocyclitis. It is similar to the muscle pain you feel a day after doing strenuous work or exercise. Other eye diseases may present as eye redness with pain and should be differentiated from uveitis. A sudden increase in intraocular pressure in acute angle closure glaucoma will lead to eye pain, redness, a mid-dilated pupil, and corneal haze. The severe inflammation and increased intraocular pressure due to the purulent material buildup inside the eye in infectious endophthalmitis will likewise generate the same symptoms, with the addition of pus in the anterior chamber called hypopyon. These two disease entities, will be discussed in greater detail in other modules. Some uveitis patients will come to you with white, normal-looking eyes, but report seeing small black things floating in their field of vision with some blurring of vision. This is what we term as floaters. Floater is actually a common complaint in the OPD, and most of the time it is benign. In fact, some of you may have this. You can check it by covering one eye at a time and then staring at a well-lit blank white wall. The complaint of floaters will warrant a thorough dilated fundus exam. Why? Because it can also be the presenting symptom of potentially blinding diseases. First, it could be the sign of a recent vitreous detachment, which is the first in a series of events leading to retinal detachment. Second, it could be small trickles of blood from a torn or avulsed vessel in retinal tear formation. The second event leading to retinal detachment, whose symptoms will include photopsias and black curtain-like field loss. Third, it could be bleeding from an avulsed retinal vessel in patients with advanced diabetic retinopathy. And lastly, the floaters could be due to inflammatory cells in the vitreous coming from an inflamed ciliary body. If left untreated, the cells gradually increase in number and form clumps. The denser they are, the more the light is blocked from entering the eye and reaching the retina. The patient then complains that his vision is becoming increasingly blurry. And on dilated fundoscopy, as a rule, if you cannot visualize the disc and the fovea, then the patient most likely sees nothing too. Finally, there are cases where the patient's eye is white and the vitreous is clear, but he is complaining of blurring of vision. These are cases where meticulous fundoscopy should be performed to check whether the retina and optic nerve are normal. In the fundus photo, you see a lot of white inflammatory materials on the retina and along the blood vessels. Inflammation of the retinal vessels and choroid is what we collectively call as posterior uveitis. This can result to severe blurring of vision, which can become permanent. The blurring can be due to macular edema or due to necrosis of retinal cells and choroid in the macular area. This photo belongs to a patient with TB uveitis. There is severe inflammation of the macular area and the optic nerve head and the retinal vessels. After confirming the patient has no active mycobacterial infection, triamcinolone powder was injected inside his eye. The steroid depot lasted for about 3 months. This resulted to a significant decrease in the inflammation. His vision has improved from hand motions to 20 over 100. This is the patient's only eye, and he was very happy to be able to see again. In summary, we have discussed the parts of the eye involved in uveitis. Depending on which parts are involved, the presenting signs and symptoms of uveitis may vary and may mimic other disease entities, such as masquerade syndrome, conjunctivitis, glaucoma, retinal detachment, vitreous bleed, and a myriad of retinal diseases. Uveitis should not be taken lightly as this could lead to permanent irreparable visual loss. Timely treatment with steroids and immunomodulators may help the patient's eye. As a take-home activity, please divide yourselves into groups of 4 and discuss how you will differentiate these diseases using history taking and physical examination. Please make an algorithm starting with a common complaint of blurring of vision. Please submit this at the end of the rotation. Thank you for listening.